Hello, welcome back to our second obstetrics and gynecology webinar, where today we're going to now be continuing our first session. And Anangsha, Kumar, over to you.
Okay, thank you. So in my previous session, I just discussed about the common obstetric conditions. It was a bit vast, so we ran out of time. So I'm going to discuss now about the common conditions in gynecology, which is not that intense or extensive, as I may say. So these are the most common. Sorry, I missed one, so I'll say tell that to you later after I finish these. Mostly the ladies who will be coming in your gynae ward or A&E, most commonly will bleep you is with either miscarriage, pelvic inflammatory disease, or with a tubo-ovarian abscess, followed by a pelvic inflammatory disease, ovarian cyst, acute abdomen with an underlying ovarian cyst, fibroid. Sorry, not acute, sorry, just ovarian cyst with some abdominal pain, fibroid, PCOS, or dysfunctional uterine bleeding. These are the most common conditions that you will come across in your gynae ward. So I've just put it, just to make life a little bit simple for you, I have just put it in one presentation for all these conditions, what you need to do, because for gynae, it's more or less the same. For these ladies, apart from taking the history, as I mentioned, it's very important you take the history and the P7 methadone, because smears, periods, pills, these are the things which is like the 4 Ps, 4 extra Ps other than the 3 Ps. It's very, very important for your gynae history taking. So personal history, past history, pap smear, periods, pills. I always keep on forgetting the rest. Personal history and contraception. Sorry, contraception. So it's C, but yeah, it has a P in it. So take your history in that format. If the lady, so as I said, a speculum examination will be quite handy, because as you can see, in miscarriage, so if she's bleeding, if you do a speculum examination, if you see that the products are literally at the neck of the womb, you can literally take a Rampley's forceps and take it out by yourself. It's not going to do her. Just make sure you don't give her a paracervical shock or something. Be gentle, give her some analgesia, give her some Gassinair, give her some codeine, and just take a Rampley's forceps and take the products from the neck of the womb out. That's it, simple. As simple as it can get. You always, if your registrar is busy dealing with cord prolapse in your labor ward, you necessarily cannot call him for a lady who is miscarrying, who has the products literally hanging at the neck of the womb. So a speculum examination can be quite handy. It can be quite handy in pelvic inflammatory disease as well, because it will give you, once you put the speculum in, if she jumps out of the bed, definitely gives you a sign for cervical motion tenderness. It can give you a good idea of any abnormal uterine bleeding, if it's heavy or not. Because fibroid and ovarian cyst, not so much. I think a bimanual examination, which will be much more handy in these cases rather than a speculum examination. So speculum for miscarriage, speculum for PID with a bimanual examination, bimanual for fibroid, PCOS, not PCOS really, ovarian cyst and fibroid to see for any adnexal mass, and abnormal uterine bleeding, again, speculum examination. So do your speculums. In cases of PIDs, infections, lady coming in with high temperature, raised CRP, do your routine bloods and everything, but take the swabs as well. Make sure that you take the triple swabs as well as a high vaginal swab. So the triple swabs generally takes the chlamydia, gonorrhea, and all the sexually transmitted infections, and the high vaginal swab, which rules out for any commensal, like any bacterial vaginosis and stuff like that. As I said, bimanual examination can be quite handy for adnexal mass, cysts, and fibroids. And cervical motion tenderness is basically doing a bimanual examination. And while you are doing it, just if you take the other hand, your non-dominant hand off, the dominant hand which you are actually doing the vaginal examination with. Once you introduce your fingers, if the lady jumps out of the bed, that is cervical motion tenderness. It's quite self-explanatory, as the name suggests itself. It's a very classical sign of PID. So in your history taking an examination, apart from the P7 maftosa, I cannot highlight how important it is in gynae examination to do your speculums, your swabs, your bimanual where appropriate, and cervical motion tenderness in cases of PID. For investigations, do the routine hemoglobin, CRP, WBC. Please do a beta HCG on these ladies. Most of them, if they are coming in with some discharge, abdominal pain spiking, and you suddenly come across that, okay, they're coming in with a beta HCG of probably 7,000. And then you realized, oh, she's probably pregnant as well. And you have given her some pain relief or which is contraindicated, or you have given her some medication which is contraindicated. So make sure she is not pregnant. Do a UPT. Beta HCG takes a little while to come back. Do a UPT. So these are the blood investigations that you will do. An ultrasound scan is something which is quite useful, and I'm pretty sure you'll be requesting for all the common symptoms as I explained, as I mentioned earlier. A miscarriage can require an ultrasound scan, mostly a TB, to rule out for retained products of conception if she comes in later on. A ovarian cyst, fibroid, definitely ultrasound examination will give you a very good idea of what's going on of the uterine or ovarian or endometrial pathology in order to rule that out. It's quite handy. In abnormal uterine bleeding, sometimes a TV scan with an endometrial thickness is quite important as well. So just make sure in gynae, mostly I'm not saying everything, but in cases of abnormal uterine bleeding, in cases of like retained products of conception, in cases of like query, silent miss, or early miscarriage, a TV, because these ladies are quite early in their pregnancy. So a TV scan has quite a high resolution, and it's quite handy as compared to a transabdominal scan. So TV is transvaginal scan. Sorry. So just mostly it's TV, but then again, if it's an ovarian cyst or something, you can pretty well see it in a transabdominal scan as well. So a scan is of utmost importance. So what will you write in the scan form? Just make sure you write to rule out any your clinical, apart from your the history that you give. What is your clinical question? Always make sure you write your clinical question. What are you looking for? To rule out any uterine, ovarian, or endometrial pathology. As simple as it gets. Like, you don't need to change for everything, because some of you might go into gen surge as your specialty. Some of you might go into something else. So if you are doing this rotation, you don't necessarily need to know the details of it, like the intricacies of like what exactly each scan is going to determine, when do I need what. No. But again, you need to be a very safe doctor, and you need to make sure as a junior doctor, you're covered from all ends, basically. And you are requesting an examination that gives an absolutely additional information to the clinical picture, to the registrar, and it shouldn't be unnecessary. If you're not sure of a CT and MRI, just discuss with your senior and make sure, and just ask them if a CT or MRI is needed. If at all, just go for it, get a CT and MRI. If she's pregnant, then again, as I said, why is it very important to get a beta HCG? Because you cannot do CTs on pregnant ladies. So from that case, you need to know, what if she comes in with some abdominal pain with a background of fibroid? You want to do a CT scan on her, and then you get to know, oh, she's not only coming in with some abdominal pain with fibroid, but she is 7 weeks pregnant as well. So then it will be better to get an ultrasound scan if it provides adequate information. If not, you can go on and do an MRI if at all need be. If you need a higher resolution, fine, go for an MRI, not a CT necessarily. In all these cases, give her analgesia, give her some tranexamic acid in cases of your abnormal uterine bleeding. You can always start her on medroxyprogesterone hormones, but that needs discussion with the senior as well. And so before starting her, make sure you ask your senior or even your colleague if he or she is a trainee, career trainee, just ask them. They would know, they would help you with that. In PID, there is a regime. Follow the BASH guidelines and not the trust or anything. So you give, depending on how severe it is, you either give IV or you give oral. So if it's IV, you generally give them a shot of ceftriaxone and then you cover them up with oxycycline and metro for 14 days. If you are thinking that, oh no, it's fine, she doesn't necessarily need IV, her CRP is 25, she's spiking a temperature of 37.2, she's clinically okay, not too unwell, clinically she doesn't look septic, fine, you'll be quite happy to start her on a empirical or prophylactic PID regime. If you're suspecting that, okay, she has lots of discharge, she might be having PID, okay, start her on the oral regime of Dox and Metro. See the BASH guidelines, check for the dosage, because the more you, like, if you're in regular clinical practice, fine, you'll remember at the top of your head, but if not, it's better to have a look at the BASH guidelines and see. But generally, it's the ones I said earlier. So this was all about the gynae common conditions of miscarriage, PID, cyst, abnormal uterine bleeding. Another thing which ladies will come in with, hyperemesis. Hyperemesis gravidarum is generally seen in the initial weeks of pregnancy, and they present. You must be thinking that, oh, she's hyperemesis, technically she should be obstetrics. No, if they are less than 20 weeks, they come to gynae ward, so they'll be admitted under gynae. So because of this period of viability. So any which way, coming in with hyperemesis gravidarum, just give her rapid hydration, give her antiemetics. So the first line will be cyclizine, and give her metoclopramide. Just don't give her metoclopramide if it's not needed. Just give her cyclizine, it should work. If you are intending to give ondansetron, just make sure that you consent, because there are a few papers and research ongoing which say that there is an incidence of cleft palate, cleft lip with ondansetron. But so this is definitely not the first line, but try with cyclizine, try with metoclopramide if deemed suitable. And if it's very severe, go for ondansetron after proper counseling, and the last will be, again, steroids. But most important is rapid hydration. Make sure her electrolytes are all right. She's not dehydrated with her urea very high, and so rapid rehydration. So Hartmann's is generally preferred, but you can give normal saline as well. You give the first bag over an hour, and then over 2 hours and 3 hours. That's what we mean by rapid rehydration. A liter over an hour, then over 2 hours and 3 hours, and ensure that she is well hydrated. Look out for the signs of dehydration. So that's hyperemesis gravidarum for you. So that was about the common conditions in obstetrics. Any questions for the common conditions in gynecology?
None in the chat. Happy to carry on.
Okay, fine. I'll just go on with the emergencies then. So then again, this I have again divided into obstetrics and gynecology. So as I said, the common conditions in obstetrics can pretty much take a very quick turn into emergency conditions, but these are the most important emergencies, which will be like emergency from the very beginning. Fetal hypoxia. Again, for this, you need to know your CTGs really well. I don't know, sometimes there are CTG reflections going on every week. Make sure you attend them and look out for the 3 signs. These are the basics of reading the CTG. So if you know accelerations, no decels, good variability, you're more or less assured that, okay, the patient is fine. So if it's a case of fetal hypoxia, how will you see? You will actually see it on the CTG, for which you might sometimes need a senior review. So in obstetric emergencies, your role will be, if there is a chance of fetal hypoxia where you see that there are no accelerations, no variability, no cycling, which is the sleep and wake pattern of the baby, it'll be less variability of 5 beats per minute, and then suddenly it will take a turn of like 25 beats per minute or 30 beats per minute. So that's cycling. That means the baby is sleeping and waking up. So when the baby is sleeping, the heart rate is low. When the baby is waking up, the heart rate is going up and making the variability to 25 beats per minute. So if you know that the basic CTG, you're happy with it, okay, fair enough, not to be worried. If you think that, oh no, there is no cycling, no variability, no accelerations, presence of decelerations, okay, you don't need to interpret what kind of hypoxia it is, but it is fetal hypoxia. So in that case, and by this, I don't mean that all the 4 need to be present at the same time. Anyone, like if there is decels present, escalate. If there are no accelerations, escalate. If there is no variability, escalate. If there is no cycling, well, depends on the clinical picture. Sometimes not always be there, but these 3 things always escalate, because fetal hypoxia is something which needs delivery, category 2 cesarean section. Your role will be, if you think that it's fetal hypoxia, sometimes it's cord compression. So the baby often lying on the cord, not getting enough blood supply, as a result, resulting in fetal hypoxia. So just make sure you change the position of the lady a little bit, put her on left lateral. That sometimes helps and the CTG improves. Give her good hydration. Sometimes dehydration can be a cause of fetal hypoxia as well. If she improves, well and good. So by the time your registrar comes in, if it's in a labor ward, a lady is seen by a personal midwife who is there with her throughout her labor. If she says that, okay, I'm suspecting fetal hypoxia, doctor, can you just come and see? You go there, you change the position, you give her hydration, you make sure you know the history of the lady and what all are her ultrasound, how is her growth, how is the growth of the baby, is that all right or not? And after you ensure everything, when your registrar comes after maybe dealing with another case of like PPH or something, or a 4th degree perineal tear, which poor guy was repairing. So if he comes back, you tell him that, okay, this is this lady, and you present the history in an SPAR format, know how her growth is, her recent scans, any risk factors, what is the current problem. Okay, I don't know how to read the CTG exactly, but I know that there are no accelerations, and that's why I'm worried. I have changed. What have you done? I've changed the position. I've given her hydration, and I've sent her bloods and everything. Her group and save, everything is done. I'm not quite sure how to go about this. So what do you think about it? So your registrar will then make a decision if she needs an emergency C-section or not. As junior doctors, or if you can assist, like I think if you have assisted if you can do the procedure from beginning to end, you can technically consent the lady. If not, then just do not consent. Make sure that the consent forms are ready. You have everything like written up and everything, but do not do the consent yourself. Make sure that your registrar consents you. If he is happy for you to consent, that's fine. But technically and legally speaking, no. As an F1 and F2, I wouldn't be asking my F1s and F2s to do a consent form. That's just not safe because there are certain complications which even I am not aware of at certain times. So that needs to be communicated with the lady really well. So a case of fetal hypoxia, first, do not panic. Do not panic. Go through her history, change her position, give her hydration, ask and escalate to your registrar because it can deteriorate really, really quickly. The other thing which can happen is postpartum hemorrhage. Very common. In that case, you get a crush call of postpartum hemorrhage. A lady has delivered a lady with like a spontaneous vaginal birth, and she has lost maybe a liter. So generally more than 500 mLs, we call it as PPH, minor and major. If it's more than 500 but less than 1,000, we call it minor. If it's more than 1,000, we call it major. So if it's major, you'll get a crush call, which is basically an emergency bleep will go out. Your role will be, so there is an obstetric emergency, like we do the BLS and the ACLS. In obstetric, it's prompt. So Prompt has a very strict algorithm of how to manage cases. This is the RCOG, by the way. This is the RCOG guidelines of what you need to do. But the Prompt has like a really good flow chart, which is available in, trust me, it is available in every labor ward room. It is just not easily accessible. So when you start your rotation as an F1 doctor or as an F2 doctor, just make sure you know where where the prompt folder is kept in your labor ward room, because they have all the obstetric emergency management algorithms. Makes your life easy. You can be the leader in any obstetric emergencies and just have that helicopter view which is needed. So what you need to do in cases of PPH, first, diagnose first if it's a PPH or not. What is happening? Has she got a 4th-degree tear, or has she got maybe a 2nd-degree tear, but she's bleeding and bleeding? And what all are the causes of PPH? It's 4 T's. So tissue, which is retained products, quite common in spontaneous vaginal birth. Trauma, tear, a perineal tear, 2nd-degree, 3rd-degree, or just maybe 4th-degree tear. Tone. Make sure that the uterus is well contracted, and thrombin if she has any coagulation disorders. So once you diagnose it's PPH, you see what all are the causes of PPH in this lady. Make sure you monitor, not you, there'll be a team. Somebody monitors her blood pressure, her temperature, her observations. Put a catheter in. That's something every one of us miss out on. Put a catheter in, put 2 wide bore cannula, green or gray. Gray preferably. Give her hydration, take bloods, and that's one part sorted. Fine, she's getting hydration. She won't be like in imminent danger of life. So now comes the prompt protocol of what you need to do. There are pharmacological management and there are mechanical or surgical management. So this is something which is a bit knowledge-based, theoretical-based, but then again, I'm talking about PPH and I wouldn't say about uterotonics. Does not make sense at all. So what you give it, generally you give 5 international units of oxytocin. The anesthetist will be there sometimes, so make sure your anesthetist is around, your senior obstetrician, your band 7 midwife, you are around as well. So you can go make sure that what is the cause of her PPH. If it's atonicity, give her oxytocin. Didn't work, 5 units. You can always start her on oxytocin infusion. So you can start her on a 40 units drip over 4 hours. That's something, again, the anesthetist will do. But that's for you to know that what are we doing? Oxytocin is a uterotonic. It will contract the uterus. It will compress the uterine musculature, as a result of which a crisscross pattern will compress the blood vessels and ensure hemostasis. You can give ergometrin, but you can't give ergometrin in cases of ladies with hypertension as well. Ladies with hypertension. Hemobate or carboprost is again something to be considered, which is 0.25 micrograms. It's a pharmacological agent which helps in controlling, ensuring hemostasis as well. The doses and everything will be properly written in the prompt algorithm. Misoprostol, not so much. In my 1 year, I haven't come across misoprostol. Generally, oxytocin. Do the uterine massage. You, as a junior doctor, what you will do is, if it's atonicity, massage the uterus. Nothing works better than massaging the uterus. Your anesthetist will give the oxytocin IV bolus, then an oxytocin infusion, which is a decision to be made by your registrar. Ergometrin, again, a decision to be made by your registrar. Carboprost, if nothing works, again, registrar decision to be made. Tranexamic acid is something you might be asked to give. So give them over 10 minutes, not 30. 10 to 15 minutes is absolutely fine. You can give a gram of tranexamic acid IV if she's bleeding excessively. And the last resort. And the last resort will be your Bakri balloon or B-Lynch sutures, hysterectomy, or interventional radiology with uterine artery embolization. But that's something really like a consultant and senior registrar level decision. For you, all you need to do is this first bit. Take the bloods, get everything ready, and you can actually lead. You can actually lead a emergency of postpartum hemorrhage, and make sure that you follow the protocol, follow the prompt protocol, which is easily available, and just go for it. And this is what is available in the prompt protocol of how to give oxytocin, followed by ergometrin, then infusion, then carboprost, tranexamic acid. And tranexamic acid you can give in between as well if you feel she's bleeding excessively. And this is all in theater, so nothing for other than getting the consent form and the lady ready. So that was fetal hypoxia and postpartum hemorrhage. I'll do these two, and then we can discuss about if you guys have any questions of in the obstetric emergencies. So sepsis is most common in pregnancy, and as I said, it will present as choriamnitis. But sepsis is quite common postnatally as well. So let me discuss about the intrapartum one, which is choriamnitis. And this will manifest as maternal and fetal tachycardia with your raised temperature, foul-smelling discharge. It's a whole clinical picture. So when a lady comes in, she is in labor, she is spiking a temperature of 38.9. She has a maternal tachycardia of 120, not settling with anything. She's not anxious. And she has got a fetal tachycardia as well. That's definitely choriamnitis. Just start her, take the, do the sepsis 6 for her. Take blood cultures, take lactates, put a Foley's catheter in, give her IV antibiotics, fluids, and if she at all needs oxygen, then fine. If not, that's fine as well. Start the antibiotic. Generally, we go for something more broad spectrum, which is cefalexin and metronidazole, but depends on your trust protocols as well. Here in Wales, we follow cefalexin and metronidazole because it's quite broad spectrum. You might need to consider delivery in case the CTG is pathological, and this non-reassuring, reassuring, pathological, suspicious, these are actually terms to interpret. It's not something I'm saying from my mind, it's actually terms. So when you hear your registrar saying the CTG is suspicious, that's actually a term which is to determine if there are certain, as I said, it will all depend on the acceleration, decelerations, and variability. But then again, it's very detailed, and CTG is a topic in itself, as I mentioned earlier. So if there are certain criteria which are not fulfilled, then we call it as suspicious. So, or pathological, or reassuring, or non-reassuring, any which way. So if the CTG is not reassuring, then you might need to consider delivery. As a junior doctor, what you will do is to recognize that it is a case of choriamnitis, to do the sepsis bundle, to start the antibiotics, to just inform your anesthetist and the senior obstetricians, and do a blood gas, very important. Do a blood gas. If a lactate is quite high, you might need to keep ITU on loop as well, just to make sure that they know that there is a lady who is choriamnitis with a lactate of probably 4, and obviously they need to act immediately. So this is choriamnitis for you. Your role as a junior doctor in the ward is nothing more than identification, which is very important, the sepsis 6 bundle, starting the antibiotics, and informing your seniors, which involves the anesthetist and the obstetricians. Bleep them, give them a good history in an SPAR format. And why do you think it's choriamnitis? As I said, sepsis is quite common postnatally as well, and the common reasons are UTI, mastitis, and sometimes retained products as well, causing endometritis. So make sure that when a lady postnatally comes in with sepsis, I take culture from everything. People laugh at me for this, but I take cultures of everything. Breast milk, vaginal swabs, urine culture, then you take blood cultures, you take CRPs and lactates and everything of that. So you basically culture everything that is possible, because the lady will generally, she has the baby to deal with, and she comes in day 7 postnatally with raised temperature, CRP of 250 or something. She might not even know what's going on. She's too busy with the baby. She's too caught up with the baby, but she's feeling unwell, so she came in. So might as well you keep your differentials open and make sure. It can be UTI, it can be mastitis, it can be endometritis. Get a scan done if you are suspecting endometritis to see if there are any bits of placental tissue left inside in cases of vaginal birth, or even sometimes in the C-sections as well. There can be bits of the placental tissue left behind, which is causing endometritis, thereby leading to postnatal sepsis as well. Send off the cultures, blood cultures, urine culture, milk culture, vaginal swabs, an ultrasound if you're suspecting retained products, and then you're sorted. And start her on antibiotics again. Before you get the culture and sensitivity, you can start her on something broad spectrum like cephalexin and metronidazole, but then again, you can always follow your trust protocols, should be okay. Eclampsia. Again, you'll have a prompt protocol for eclampsia. It is the most important. I cannot highlight how important it is. Preeclampsia with eclampsia is a topic in itself, which incorporates severe hypertension, severe preeclampsia, and eclampsia. So if you want, I've just put in algorithms because it just makes your life more easy of how to manage severe hypertension and how to go about it. As I mentioned, what all are your antihypertensive preferable in pregnancy, which is labetalol, nifedipine, and alpha methyl dopa. So this is the pro forma. This is the RCU. This is RCU1. This is what you follow in cases of severe hypertension. So severe hypertension per se is not an emergency. The only thing which you need to do is rule out preeclampsia, which is hypertension with proteinuria or other neurological signs and symptoms. So that's preeclampsia for you. So what you need to do is stabilize, monitor, and birth. Planning the birth is most important. What causes preeclampsia? Deliver the baby, and it will be sorted. Yes, it does take time and it has been seen that I think the RCOG says 10 to 20% of eclamptic episode does happen postnatally as well. But most commonly with delivery is the treatment for preeclampsia, other than your magnesium sulfate and the antihypertensives, as I mentioned before. So in this case, if she is if she is quite hypertensive, you'll start first with oral, then you go on to IV. You can always consider hydralazine as well, IV hydralazine, if it's not really controlled. So it might be a lot of information for you to take in, because preeclampsia, and eclampsia is a very vast topic. But I'm going to tell you what's going to make your life easy as a junior doctor. That red prompt folder, which has everything literally written in a format, in an algorithm. You can just grab hold, it's a laminated one, grab hold of one and just stand on the head end of the bed if you want to lead, and just make sure everything is being done. Measuring the blood pressure, giving her orals. Okay, orals didn't work. Did you repeat the blood pressure again? Okay, repeated blood pressure still high. Fine. Did you give her IV hydralazine? Okay, fine. If the criteria is crossing, do you need magnesium sulfate? In cases of magnesium sulfate, there are things you need to look out for: respiratory rate, urinary output, knee jerk, because these are the things that magnesium sulfate causes an impact on. So just make sure that you have that prompt folder, which has the details of how to manage preeclampsia and eclampsia. So you don't need to remember every bit of this eclampsia and preeclampsia, as I mentioned before. Only having that folder will be more than enough for you. But just to give you a little idea of what if a lady throws fits, how to deal with that. You give 4 gram IV over 5 minutes. You will not be giving it. Generally, the anesthetist will be giving it, to be honest. But then again, if I don't know, if your registrar is happy for you to do it, then fine, go for it. And with a maintenance dose of 1 gram IV for per hour, that's what you give. And then you make sure that you can repeat it again if she doesn't throw a fit in the last 24 hours. that's fine. You stop it. If not, you repeat it again, which is a 2-gram bolus over 5 minutes. So this is again a chart. You can follow it, but in order to be medico-legally safe, a prompt is something to fall back on. Sorry, I will go on. Right. So fetal hypoxia, postpartum hemorrhage, eclampsia, we have covered. Oh, we have covered sepsis as well. Perfect. Any questions so far? I know that was a bit extensive. This gynecology one, emergencies, it won't be much, trust me. So any questions in the obstetric part?
Questions. Let's move on.
Okay. So in the gynecology, ladies will either come in with ectopic, in the emergency ones, ectopic or acute abdomen. So in acute abdomen, you take a history, because sometimes A&E will send even a patient with ruptured appendicitis to gynae if she has a little bit of PV bleed. So take a good history. Make sure, where is she bleeding from? Is it a hematuria? Is it a hematochezia? Or is it actually a pervaginal bleeding? And examine her for guarding, rigidity, rebound tenderness, any signs of peritonism. Do a beta HCG on these ladies, because it'll give you a lot of idea of what is going on. Before you go on into more extensive history taking, offer her pain relief, give her good hydration as well. And then if you find that, okay, fine, it's an obstetric cause, seems like an obstetric cause, what all are the acute abdomen causes, causes of acute abdomen gynecologically? It can be ovarian torsion. Most commonly it is ovarian torsion. Or if it, that is it actually. So if you do an ultrasound scan, make sure you add a Doppler to it. Suppose it's 12 o'clock in the in noon. Lady comes in with like guarding, rigidity, rebound tenderness, and surgeons have reviewed. They have said that, oh no, she does not have appendicitis or any other causes, or any other gen surge causes. Fine, you do an ultrasound scan. And if you're suspecting that, if she gives you a history that, oh, I have had previous dermoid cysts before, or I have had cysts before, fine, you do a scan. Or if you think that, no, she doesn't have history, but still it looks like an ovarian torsion to me, fine, go for a scan with an Doppler. Keep her nil by mouth, because in case you are suspecting it's an acute abdomen, please keep her nil by mouth. Do the routine bloods. Put her on the CPOT list after talking to your registrar, because this is actually an emergency. You need to argue that, oh, this is not a life-threatening emergency, but this is an organ-threatening emergency. We need to operate on her. Sometimes doing a oophorectomy is not always the option. You can always untwist, but that's again a very complicated, controversial topic, which is something to be dealt with by your seniors. What you can do from your point of view is do a good examination, get her scans ready, get the results done, keep her nil by mouth if you're suspecting acute abdomen, do her routine bloods with a group and safe on board. Don't do unnecessarily further imaging if at all it's not needed. If you're suspecting acute abdomen, put her on the CPOT list. You can cancel her off if it's not needed. Make sure that the consent forms are ready. The anesthetist is kept in loop, and obviously your senior knows it as well. The other thing is, again, ectopic pregnancy. What you do is a beta HCG. So ectopic pregnancy is pregnancy anywhere outside the abdomen. So do a repeat beta HCG, repeat it in 48 hours, do a scan, and depending on her clinical picture, you can either go for a medical management or a surgical management. And for her as well, you need to do her